Good evening, ladies and gentlemen. I am 𝗏𝗃𝗍, and on behalf of Voice of Healthcare, I welcome you all to this virtual session. Since 2010, Heart Failure Awareness Day has been one of the most significant events organized by European Society of Cardiology. This is an opportunity to bring the realities of heart failure to the forefront of awareness in order to be catalysts for change in heart failure treatment paradigm. In 2026, Heart Failure Association of India takes a step forward during Heart Failure Awareness Days to raise awareness about the importance of recognizing symptoms of heart failure with LVEF greater or equal to 40% early, getting an accurate diagnosis, and supporting patients with optimal treatment. Presenting Beyond Ejection Fraction, an initiative designed to share practical insights on the evolving understanding and newer therapies in heart failure with LVEF greater than or equal to 40% within cardiology fraternity. Also, we aim to move beyond numerical interpretation of ejection fraction and highlight how real-world clinical judgment, patient profiling, and multidisciplinary perspectives shape contemporary heart failure management in LVEF greater than or equal to 40%. This initiative is supported by Bayer as educational partner and Voice of Healthcare as digital partner. It is my extreme pleasure to introduce our esteemed speakers for today's session. Please join me in welcoming Dr. 𝗏𝗵𝗱𝗆, Vice Chairman, Clinical and Preventive Cardiology, Cardiac Care, Medanta Medicity, Gurugram. Welcome, sir. We have Dr. 𝗨𝗵𝗱𝘆, Consultant Cardiology, Cardiac MRI and Cardiac CT Department, MGM New Bombay Hospital. Sir would be joining us. Dr. 𝗨𝗵𝗱𝗆, Consultant Cardiology, Manipal Hospital, Kolkata. Welcome to the session, sir. And today's session would be led by our chairperson and moderator, Dr. 𝗏𝗵𝗱𝗆𝗁, Senior Director, Cardiac Sciences, Cardiology, Interventional Cardiology, Max Healthcare, Saket. Dr. Chopra, over to you.
Thank you, 𝗏𝗃𝗍. I think it's a very appropriate introduction. Can we have the next slide, please? So it's a tight session. We have a lot of material to cover. So without wasting any time, let's start off straight away. So we are going to discuss about heart failure with ejection fraction over 40%. Why is it important to discuss this particular aspect? Next, please. So I have a very learned faculty who is going to be elaborating upon this program. Next, please. Next. So, heart failure with preserved or mildly reduced ejection fraction is something which has gained a lot of importance of late. The aim of this particular webinar is to describe why is it important to understand and diagnose ejection fraction over 40% as a component of heart failure. What are the patient profiles which require the treatment, especially finerenone, which is a new kid on the block, and how do we take practical decisions around timing, sequencing, and guideline-directed medical therapy and monitoring them in this group of patients. Next, please. So this is going to be the floor. Dr. Sanjay Mittal is going to make a presentation about MRAs in the management of heart failure with ejection fraction over 40%. Dr. Uday Yadav and Dr. Sumitra will take us through two cases, one with heart failure, preserved ejection fraction with worsening symptoms, and Dr. Sumitra Ray will enlighten us how to deal with a patient who has recently been discharged after a diagnosis of heart failure with preserved ejection fraction. So that is the flow, and at the end, we'll have a small discussion. Why? Next, please. So why is this important? In the minds of many clinicians, if you do an echo and ejection fraction is over 40% and especially over 50%, it is equated with no heart failure. And these patients are often passed on to pulmonologists or psychiatrists saying that there's no heart failure. But it's very important to recognize this entity. In the Western world, this incidence is rising and it is over 50%. In our country, the recognition has been slow. Maybe also the incidence is not as much as it is in the West, and there are a number of reasons for that. But regardless, this carries an equally bad prognosis, requires repeated hospitalizations. Next, please. Next, please. And we know that patients in heart failure present at a relatively younger age. They exhibit more severe clinical profiles because of high incidence of diabetes, hypertension, high incidence of smoking, adverse lifestyle, and so on and so forth. So although globally more than 50% of patients now are recognized as having heart failure with preserved ejection fraction, in our registries, the incidence is close to 25%, but it is inching up slowly. It is also because we don't recognize, but maybe the incidence is truly not as much as it is in the West for various reasons. Next, please. So this is a slightly old slide of recommendations from 22 and 23, which tells us that heart failure with mildly reduced or preserved ejection fraction should be treated this way. We have a number of wonderful therapies for heart failure with reduced ejection fraction in terms of ACE, ARB, ARNI, beta blockers, SGLT2 inhibitors, and MRAs. But the evidence for heart failure with preserved ejection has been largely limited. Until very recently, it was management with diuretics and management of comorbid conditions. Now, recently, with the entry of SGLT2 inhibitors, ARNIs, and newer MRAs, this scenario has changed, and that is what we are going to discuss today. Next, please. These are two trials which are done. Emperor Preserved was heart failure with preserved ejection fraction in patients with empagliflozin, and Deliver trial dealt with the same group of patients with dapagliflozin. Both of them were SGLT2 inhibitors. But we still realized that in both of these, despite being on very good baseline treatment of RASI nearly 81%, MRAs not that good, nearly 40%, and beta blockers in about 85%, there was still a significant incidence of cardiovascular death and heart failure hospitalizations coming to between 14 to 15%, 16%. Next, please. So the messages are that patients with heart failure with ejection fraction more than 40%, remember 40 to 49 is mildly reduced and over 50 is today considered to be a preserved ejection fraction. They face a higher burden of heart failure events, almost similar to heart failure with reduced ejection fraction. And there are a number of comorbidities. This is a disease of relatively older age. So this combined with the problems which occur with old age, they exacerbate the risk of death. So there are critical gaps in the care of these patients, and that which is attributable to high residual risk. So therefore, we have to devise strategies. There's a lot of new information available, and that is going to be discussed with our colleagues. So with that, let me pose the first question. Next, please. Let me ask a panelist, Dr. Mittal, Dr. Sumitra Ray, and Uday, are we neglecting this disease severity in ejection fraction of more than 40% by emphasizing mainly on ejection fraction? Is that kind of focusing on EF a little bit more? Or should we have a broader assessment of clinical events and progression? Sanjay, start with you. Very, very brief comments. Time is limited.
Thank you, Dr. Chopra. I think this is a very pertinent question, and I totally agree that we have been misled with ejection fraction as a marker of heart failure. And I think I agree with you on one count that we are underestimating heart failure with preserved and mid-range ejection fraction in our country. It is not so low because it falls in some others' purview, non-cardiologist purview. And I think this is equally dangerous, as very rightly showed by you, but we should focus more on the failure symptoms rather than the ejection fraction.
Right. So Mitra, anything to add?
Yeah, I think ejection fraction is important for long-term treatment, but if you see the acute heart failure trials, important trials hasn't taken ejection fraction as a criteria. When the patient is admitted as acute heart failure, soloist heart failure and other things, ejection fraction is not a criteria. So acute heart failure, you treat as a heart failure on symptom and signs, not on ejection fraction and the patient's congestion. So maybe for long-term treatment, you can differentiate and you try to get evidence on either side. But ultimately they are same. And as the days goes by, most of the medicines which are used in HFpEF are getting footage in the HFpEF arena as well. So I think this area is getting blurred.
Thank you, Soumitra. Dr. Jadhav, anything to add?
Thank you, Dr. Vijay. My comment is that yes, we get away from the EF-centric approach and start looking at EF as a spectrum rather than dividing it into figures of 30s and 40s and 50. So the benefits of some of these medications, for example, in this classroom discussion on finerenone, is across the spectrum of the ejection fraction. And that translates into benefits in all clinical events in terms of decreasing the progression and actually getting more organ protection. Thank you.
Absolutely. Agreed with you. You know, ejection fraction is something which is a moving target. So is 39% really different from 41 or is 49% really different than 51? We know it's a moving target and it can change. So with that, let me invite Dr. Sanjay Mittal to give his talk and tell us about this particular entity. Sanjay, over to you.
Yeah, sure. So I'll share my slides. You can switch off your screen, please. Okay. So what I'm going to do is okay, here. I think my screen is visible, right?
No.
Right. So I'm going to talk about this new class of medications and the new evidence which we have received, which is going to possibly change our scenarios much. You know, let's talk about the mineralocorticoid receptors and aldosterone-mediated problems. You know, as we started talking about the mineralocorticoid receptor overactivation, we thought mainly about the sodium and fluid retention, which is one of the things that works through the kidneys. But there's much more to go, and it has been realized much more that inflammation and fibrosis, it has a lot of hemodynamic effects, that is vasoconstrictions and increase in elevation of systolic pressures. And also along with that, it leads to, in chronic term, the cardiac and vascular hypertrophy, both of which lead to furthering of glomerular injury, fibrosis, and kidney failure. And on the other hand, the cardiac fibrosis and remodeling, which in itself lead to each other's damage. So this is a vicious cycle which sets on. The other thing is that if you talk about the antagonism for these mineralocorticoid receptors, it started with 1960s advent of spironolactone. And then we had a lot of data on spironolactone and eplerenone heart failure with a reduced ejection fraction, as Dr. Chopra was mentioning. However, when it was extrapolated, spironolactone specifically, to heart failure with preserved ejection fraction, it was a failure in TopCat study. Well, arguably, but it was a failure. But recently, there has been advent of new generation or next generation's MRAs. And the case in point today is finerenone, which has experience of more than 20,000 patients. It started with type 2 diabetes and kidney disease, we all know, but have enough data now to say that it is a cardiovascular drug and specific for mid-range and preserved ejection fraction. I'm going to discuss about the data. The other thing about the various available MRAs is that they differ in all aspects. If we talk about the difference in the mechanism of action, there is difference which we know as of their efficacy is concerned, and there is difference in what we call as their safety indices are concerned. So let me talk about the first thing first, the old and gold spironolactone. And I think eplerenone behaves the same way, except for the fact it's much more selective for mineralocorticoid receptors and less so for the steroid receptors other than mineralocorticoid, and that is why the side effect profile is less. But both of these are steroidal they're small, flat type of proteins, which actually engulf or attach to the mineralocorticoid receptors and make those receptors not available for aldosterone. But yet what happens is that in spironolactone's case, there is a lot of metabolites which are also active, and that is why the half-life is too long. Secondly, because they are small ones, what happens is they do not completely negate the effects of mineralocorticoid receptors, and there is a site available for the other, what we call as co-activators, which can be circulating and then can still lead to some kind of mineralocorticoid activity. That is why they say that the spironolactone and even eplerenone has a partial agonist activity for mineralocorticoid action. So thus, what happens is that spironolactone has a long half-life because of the fact that the metabolites are active as well. It has cross-sensitivity to attachment to androgenic receptors, which leads to the gynecomastia and other side effects, has higher chances of risk of hyperkalemia, mainly because of the long half-life, and also has a greater effect on the blood pressure than finerenone because it has other effect on non-mineralocorticoid receptors as well. On the other hand, if you look at the non-steroidal finerenone, it is a large molecule, bulky stuff, which leads to attachment to the moieties here, and by sheer size of it, it actually makes the mineralocorticoid receptor dysfunctional, not even available for the co-activator factors, which means it's near total obliteration of mineralocorticoid activity. However, because the lifestyle span is small, short, just 2-3 hours, it does not lead to a severe hyperkalemia. So in a nutshell, what would happen is that there is no evidence of side effects because of the fact that it is very selective to the mineralocorticoid receptors. There is minimal chance of hyperkalemia, and also there is minimal effect on hypertension or lowering of the blood pressure. And mind it, because it is a complete total effect on the mineralocorticoid receptors, it leads to a lot of transactions into the mRNA synthesis, which is responsible for many of its effect on the mediators of fibrosis and inflammation. So this is the comparative slide, what I have already mentioned, and there has been observation that the finerenone in animal studies has shown that gene expression, specifically targeting the fibrosis and inflammatory process, is much depleted as compared to the steroidal MRAs, where such kind of a thing is not happening. The comparison was with eplerenone in this case. So in a nutshell, what is important is, if we compare spironolactone, finerenone, and eplerenone, the potency was maximum with the finerenone as far as mineralocorticoid receptor is concerned. And also, to summarize, the effect as far as kidney damaging effect and hyperkalemia is minimum with finerenone. And also the fact is that there is data now in the form of the fine art study, which actually leads to its efficacy in ejection fraction above 40% heart failure. So that is something which I'm going to dwell a little bit more. The second component which I'm going to talk about today is what is the evidence about the differences in the efficacy of the various MRAs. So let me start with the data from various trials as far as the kidney disease is concerned, because that is how it emerged from. Fidelity, we all know about 13,000 patients with CKD, which was stage 1 to 4, along with diabetes, with a UACR of more than 30 milligram per gram of creatinine was actually mentioned here. And it was found in this group of people, there was about 14% reduction in CV death and morbidity, as well as 22% reduction in heart failure hospitalization. Although these patients were not primarily heart failure patients, but there still was a reduction. And if you talk about the kidney outcomes, it was also reduced by 23% as far as the kidney progression is concerned, and 20% hard endpoint of end-stage kidney disease emergence were also observed in here. And compare this with what we have evidence, although the evidence is limited, but this is a beautiful trial, BARAC-D, which was basically on spironolactone, about 1,300 odd patients, and it was found that spironolactone was no different as far as heart failure events are concerned, and these people were actually CKD patients with albuminuria. Minded, there was also about 32% reduction in albuminuria in Fidelity trial. Let's talk about the second component of it. Let's not talk about the kidney disease. Let's talk about heart failure, people. And if we talk about heart failure with ejection fraction above 40%, a fine art study we have been talking about was on finerenone. It was randomized study between placebo and finerenone, with the rest of the study, the medications being continued like this. And it was about 16% event rate reduction, mortality as well as heart failure hospitalization composite, inclusive in over 3 years of time. And what data we have for other MRAs is basically dependent on the data from 2 trials, but both of them have been on spironolactone. TOPCAT has been talked about. There is some Georgia-related fiasco, but yet there was a marginal decrease in heart failure hospitalization, but mortality and CV death and heart failure hospitalization combo was not statistically significant different over the period of nearly 72 months, which was much more than the fine art study. There is a small study which is also available for the data analysis of SPIRIT-HF, where also there was hardly any difference. Rather, the trial was prematurely withdrawn because there was a little increase in event rates in the blue arm, which is the spironolactone. So the data which we have is on steroidal MRAs was not favoring continuation of the treatment as far as heart failure hospitalization, preserved ejection fraction, or mid-range ejection fraction is concerned. And if we draw, as Dr. Uday was mentioning, the continuum of ejection fraction from 40 to 75 for both the drugs, the steroidal on the right side and the non-steroidal on the left side, there is a continuous benefit. The blue line, dark line, is below the dotted line, which means favoring finerenone as far as outcome is concerned. And this, the p-value, the light blue curve, also being less than this till the ejection fraction of 60%. Whereas spironolactone, if you talk about from the TOPCAT study, it crosses within 55% the central point, and there is hardly any benefit of the outcomes beyond preserved ejection fraction group. We talk about acute heart failure. Limited data from the steroidal MRAs, but we had a subgroup of the fine art study, whereas almost 50% of people did have recent onset heart failure, less than 7 days or 3 months, and both of these groups showed substantial improvement in outcomes, almost 21 to 25% improvement in the outcomes with finerenone as compared to the placebo. And on the other hand, there is a small data set of 360 patients available for 𝗤𝗄𝗄, which was an acute heart failure setting, high dose spironolactone versus 25 milligrams spironolactone, and no definite indication of any kind of benefit was observed. Although this is not spironolactone against placebo, but low dose spironolactone vis-a-vis high dose spironolactone, no benefit was seen. There was some also data on the presence of finerenone in as far as a new onset of atrial fibrillation is concerned. There was substantial detection, almost 23% reduction in events of atrial fibrillation in fine art study. However, in TOPCAT study, there was no significant difference. Rather, there was a slight increase in incidence of about 20% in atrial fibrillation people on spironolactone. So that is the efficacy part. Now, safety, that is a major concern for all us cardiologists. And let's talk about the smallest thing. First thing, if we talk about the discontinuation, in fine art study, the discontinuation because of any side effects was matched. placebo equal 21%, and 𝗡 equal 21%. As far as 𝗏𝗏 is concerned, the lower the beginning eGFR was, the higher the discontinuation rate, almost 10% to begin with, if the GFR was less than 45%, and if the GFR was above 60%, the discontinuation rate was lesser. And that also proportionally matched with the efficacy. SPIRIT-HF, as I was discussing about, was during the COVID times, but there was almost 50% of people who had down escalation or temporary withdrawal of spironolactone as much as within 21 months of starting the drug in this particular trial. So that means it is not supposed to have that kind of a safety data. And lastly, I would also talk about a meta-analysis which was available. We have been talking about the Georgia fiasco, but let's talk only of America's 𝗏𝗏. In that also, there was a little higher incidence of hyperkalemia as compared to the fine art study with finerenone. And that is why the hyperkalemia chances is supposedly favoring usage of non-steroidal finerenone rather than the steroidal MRAs. And that goes back to my summarizing why finerenone should be considered as far as available data is concerned. We have a few highlights here. If we talk about indication as far as approved benefits in mortality as well as heart failure hospitalization, available only for finerenone, not available spironolactone. This trial was successful, as I said. Treatment effect was regardless of ejection fraction. We knew up to 60-65% the benefit lasted. Treatment effect regardless of recency of heart failure event, and reduces risk of new onset of diabetes. That is something which is so very important. That data is not available for spironolactone. Reduces risk of new onset atrial fibrillation. That is something which I have already shown you. Risk of sex-related adverse event was practically negligible with finerenone, and significant, about 10% more in spironolactone group. Risk of hyperkalemia was very low in 4 weeks as compared to the spironolactone group, and the selectivity is very high. So these are, ladies and gentlemen, the summary of what we have, the data as far as the types of MRAs concerned, non-steroidal vis-a-vis steroidal MRAs. So I would end my talk here and leave the stage here with a directed question to the panelists, Dr. Chopra, Dr. Uday, and 𝗏𝗵𝗱𝗆. What factors should guide our personalized treatment plans for HFpEF and mid-ref? Particularly, the question is regarding the MRAs. So I'll stop sharing my screen here and go and ask our senior most guide here, Dr. Chopra, to comment on this.
Thank you, Sanjay. It was a wonderful talk, and you have summarized everything so well in such a short time. The guidelines very clearly mention that at present, the steroidal MRAs are indicated for heart failure with reduced ejection fraction, and non-steroidal MRAs, that is finerenone, is for heart failure with preserved ejection fraction. And fine arts data which we published also showed that it had benefit in heart failure with mildly reduced ejection fraction. As the experience builds up, new data may emerge, but there's no doubt that with finerenone we have data from renal studies also, Fidelio and Figaro and so on and so forth, indicating its safety and efficacy in diabetic kidney disease, which is an important component in the group that we are discussing. One thing about fine art, 𝗏𝗏 we know it was a flawed study for various reasons. But as you rightly mentioned, even if you take the data from Americas, which they keep quoting, there again the incidence of hyperkalemia was significant. So this is what the guideline is at present, and we must also remember that once SGLT2 inhibitors are added on, the risk of hyperkalemia becomes less, which wasn't there in 𝗏𝗏 study, but to a small extent it was there in fine art study.
Yeah.
So with that, let's ask the others. Uday?
Yeah, so my take on this specific question is that as a clinician, this should become a clinical class 1 indication when you start looking at a LVEF that is preserved to some extent, whether you call it 40% or 50%. It's across the spectrum. It's certainly going to benefit HFrEFs. But as you go and beyond 50s, or you see those patients who have an element of preserved ejection fraction and clinical heart failure, this should become like a class 1A indication. And we need to upstart finerenone. And there is a definite difference between finerenone and the older MRAs, as we'll see in the further slides. Thank you.
Soumitra?
The only important thing is that from the previous trials, now in this particular heart failure arena, finerenone is now free of diabetes. You don't have to have diabetes to give finerenone, and you don't have to have ARB on board to have finerenone. So these are the two important shackles finerenone has thrown away while being promoted in the heart failure premise instead of that kidney diabetic premise. So it is, I think, it's a big leap, and it gives us freedom to use finerenone in all HFpEF cases and mid-range cases. So that we should keep in mind.
So can I just poke my nose, as I usually am habitual of? We talk about mid-range ejection fraction. What about the improved ejection fraction group? Today, the criteria is not to stop MRAs. A person who is been on spironolactone or eplerenone, now ejection fraction is 45-50. I mean, would you venture out changing to finerenone?
So I think that's what my take, and then others can give the correct answer. If somebody has been on reduced ejection fraction and with spironolactone or eplerenone, they have reached mildly reduced or improved ejection fraction, there's no reason to stop that. I don't think those are the people who would be shifting over to finerenone. So, Uday, maybe you can give the...
I think so. The patients who go from reduced to improved, in the first place, that's a therapeutic benefits. So the reason to improve is the therapy, of which MRAs are absolute fundamental reasons, and therefore to go back upon them, as was shown even with 𝗏𝗏𝗏𝗏 would not be a wise thing. I think once you get into the improved phase, you still need to continue the same way. Doesn't make sense. Thank you.
Soumitra, agreed?
Yeah, absolutely.
Okay, so I think since the time is short, let me now invite Uday, who's going to take us through, Uday and Soumitra are going to take us through some of the practical cases. Uday, first to you.
Sure, yes, please. I will. These guys will help me with the slide, just to make it quick. So here is a case of HFpEF patient with worsening symptoms. Please carry on the slides. Move the slides so I can continue to lecture what happens. Next slide, please. Next slide, please. Right. So here is a patient who is a 70-year-old man with CKD, obesity, symptomatic HFpEF, and has come 5 years ago diagnosed with CKD on a ARB, and in 1 month has come with visit to the emergency room, short of breath, prescribe a steroidal MRA and a diuretic. So you can see his journey from 10 years, diagnosed with obesity, having a weight gain, then goes on to develop a heart failure with preserved ejection fraction on a SGLT2 inhibitor and a GLP-1 receptor agonist. He has now an appointment scheduled for worsening over a period of time his clinical status. So that's what his whole history is. Let's see this journey and see what we can do about it. Next slide, please. Right. So if you look at his clinical profiles, his HbA1c is 5.7, reasonably controlled. His blood pressure is 120/73, obese. Potassium is 4.9, so we keep that in mind. eGFR is moderate, 45 ml. There is a microalbuminuria with a USCR of about 150. LVEF is 54. He is in 𝗩𝗏𝗏 class 3 with a KCCQ score of about 55. So then we now go to the treatment considerations. Next slide. He's on maximum tolerated dose, right, of all the prescribed tolerated doses, and I think it's time to move away from ARB for certain. So that's a simple message I wish to give, that we have to move away from ARB to something that's proved for heart failure with preserved ejection fraction. Next slide, please. And Then we look at the residual risk. Why do we need a MRA on board? And when you look at more than 40, as Dr. Vijay Chopra was explaining in his initial slides, finerenone plays an important role. Both preserved and delivered with 𝗵𝗃 and 𝗍𝗃 are still at a residual risk. So that residual risk was 13.8 and 16.4. So let's say close to 15% of the patient in clinical practice for sure. Now, this is a data that comes from a well-controlled trial, but would still require something to keep the EF well preserved and have lesser clinical events. Next slide. Here is the data with spironolactone and finerenone. I have been answering these questions in few meetings in recent times that is there a change from spironolactone with finerenone? And in the next 3 slides, we'll look at it carefully. But here is the data with TopCat. So if you look at the place where the cutoff really starts happening, somewhere around 52, 54, you start losing the benefits with spironolactone in terms of events, CV death, cardiac arrest, of hospitalization or heart failure. And you see the blue bars in the finerenone, it's very consistent, irrespective of what EF you are looking at and what are the benefits. So across the spectrum, I think this makes a lot of sense. Next slide. Here are the benefits that would happen in pre-specified events with giving finerenone and not giving finerenone. Certainly you have benefits for CV death, for sensitivity analysis of CV death, including unknown deaths, and then some of the important secondary endpoints which I believe are important in terms of what clinical events can be prevented. So kidney composite endpoints, the heart failure hospitalization, CV deaths or heart failure hospitalization. And as Sanjay was mentioning a while ago, it's very nice to look that the new onset atrial fibrillation would also go down by about 17%, statistically significant. And that's something you are always concerned with HFpEF, because that's something that's actually driving their morbidity and mortality to quite some extent. So besides everything, some of the secondary endpoints in clinical practice stands to reason of benefit. Next slide. Right, and the quality of life improves. So if you look at the Kansas City cardiomyopathy questionnaire and the total symptom scores as compared to placebo with finerenone, there is a statistically significant change, right? So this is something which is very consistent with which we also looked at in the SGLT2 inhibitor trials. So as an add-on, after the SGLT2 inhibitor trials, finerenone certainly makes this great difference to the patients of HFpEF, and quality of life is extremely important to HFpEF patients. Next slide. Finerenone also lowers the risk of developing diabetes in patients. Now, that's a little interesting as to what has happened with patients who had high blood sugars. And spironolactone did cause a little elevation of the HbA1cs. With finerenone, you do get a drop of new onset diabetes. And this is something which is looked at by the HbA1c data. And if you look at the larger analysis of HbA1c, this is the finerenone data with more than 13,000 patients. This benefit versus placebo was very consistent. So that was across all the HbA1c quartiles, HbA1c variability, the duration of diabetes, and insulin use. I think this is something which was reflected in the very first year of the clinical trials. And so irrespective of how the diabetes control is or how the HbA1c changes, this is a great benefit. Next slide, please. In terms of the benefits for kidneys, as has been well mentioned, when you looked at TopCat with spironolactone, there were worsening kidney reports, there were permanent study drugs discontinuation. Compared to that, we will see as in finerenone, the spironolactone data was very different. In BRACD also, you found some safety concerns and some impairment in the kidney function. Next slide. And then when you look at finerenone in the next slide, you'll see the difference of what can happen. Next slide, please. Yeah. So here is fine arts heart failure study with potassium. And the important thing, which was also noted at that time with ARNI trials, is that you get much lesser hypokalemia. Now, hypokalemia actually is a big trouble in heart failure across the spectrum. The same story for HFrEF, the same story for HFpEF. So you want to preserve potassium. Naturally, you have an element of higher potassium and a higher hyperkalemia for finerenone use, both for 5.5, but very less for 6. Important is that this does not lead to any deaths either from hypo or hyperkalemia, and hypokalemia of course was lesser, and did not actually lead to a significant increase in requirements of other medications to get the potassium down. Just the adjustment of dose and correcting the factors that increase the serum potassium helped in this class of patients. Next slide, please. All right, so that's the question that may come up quickly to the panel, that how finerenone will reshape our approach to managing patients with HFpEF and HFrEF compared to the steroidal MRAs, and do you see that difference with spironolactone? I, for one, feel, and I'm saying that straight away upstart, that I do not see why patients who otherwise we think are comfortable on spironolactone should not be changed to finerenone after looking at the finerenone data. I mean, I used to always think, well, I will not do this in clinical practice, and I had my own little, reservations. But when I look at the data carefully and I look at the clinical profiles, I think not everyone, but I think there is an element of patients whom you can change from spiro to finerenone. So Dr. Vijay and our panel, please quickly.
Muted.
If you may, yeah.
Dr. Vijay is muted.
Thanks, Uday. Again, a wonderful presentation of a case, and thanks for teaching us. So to me, 3 points stand out. One is, in heart failure patients, we must estimate urinary albumin creatinine ratio. It is as bad a marker as elevation in creatinine or reduction in GFR. Our nephrologists are very keen on measuring it. Somehow the other cardiologists don't measure it. And elevated UACR is again a prognostic marker, and finerenone helps in that. Second, atrial fibrillation reduction is very important, because if you see an elderly person with dyspnea and atrial fibrillation, assume that it is going to be HFpEF. So I think these are the 2 points which really stand out. I am pretty sure that given the advantages, as Uday, you rightly mentioned, in future, even heart failure with reduced ejection fractions will be benefited by this drug. There's no reason why they can't be using this drug. So that's what I have to say. Soumitra, what do you say?
Yeah, Dr. Chopra, actually, in HFpEF, the area is so narrow. We don't have much luxury to toy with various molecules and trial and error. We have got hardly 2 or 3 molecules which are approved. So it's our duty to give at least those 2-3 drugs to everybody if there is no overt contraindication, because our options are very limited, and these data are so hugely in favor. I think there should not be any hair splitting analysis unless contraindicated by I give to everybody, because I don't have much other things to give or offer.
Right. Sanjay?
Yeah, well, very quickly, I totally agree with you. The only thing is that this availability of 3 options now for HFpEF and HFmidRef should excite all of us to actually look for it energetically. And as you very rightly said in the first slide, that probably the underreporting of the HFrEF and HFmidRef and HFpEF in our country should now be looked down upon. And as a matter of principle, I am actively educating and looking forward to finding it out and treating with these 3 molecules.
Yeah, and from Heart Failure Association of India, we are running a lot of programs educating people and our physician colleagues about HFpEF, which is certainly an underreported entity. Okay, so Soumitra, over to you.
Yeah, thank you. Let me share first.
Yeah, we can see that. We could see your slide, Soumitra, earlier.
Yeah, but it was from their side. Now I can manage it
Okay.
from my side. Okay.
Yeah, fine.
So you can see it now?
Yes.
Okay. So yeah. So thank you, Dr. Chopra, Dr. Mittal, Dr. Yadav, all the delegates and team by over here. I am quite happy to present a case given to me. Let's see this lady who was given to me. 62 years old lady with HFpEF, type 2 diabetes, hospitalization for heart failure 5 days ago with ejection 62% on SGLT2 diuretic, ACE inhibitor and beta blocker. So this is a lady who had 8 years ago complained of fatigue during everyday activities. Then 7 years ago diagnosed with heart failure with ejection fraction normal and hypertension, and was given diuretic, ACE inhibitor and beta blocker. We can always discuss beta blocker, but this is not the forum. 1 year ago, complaints of edema in both legs and diagnosed with diabetes and prescribed SGLT2 inhibitor. She was already on diuretic. 5 days ago, she was hospitalized with congestion, up-titrated diuretic dose and condition stabilized. So that is the clinical profile. The presentation, as I have already mentioned, on investigation, there is uncontrolled diabetes. Pressure is to some extent just outside the range, 130/185, not below 130/80. eGFR 65, UACR 15, so well below 30, that is good. Ejection 62, 𝗍𝗏𝗃 class 3B on SGLT2 diuretic, ACE inhibitor and beta blocker. And treatment consideration. What are your primary concern for this patient? The need for early or immediate clinical benefit following treatment initiation to prevent the second hospitalization. She's just discharged from hospital. An increased risk of adverse clinical event in this patient, both short-term and long-term. So this Dr. Chopra has showed at the beginning of our session that they are not out of events. They are quite as bad as HFpEF patient in terms of prognosis, outcome, hospitalization rate, and everything. Time to first benefit of finerenone in patient with heart failure. If we see here how finerenone acts, that we have seen, but how quickly it acts, whether it can prevent the second hospitalization. So here, if you see the first significant reduction in cardiovascular death and total heart failure event occurred within a month. The significant point, p-value became 0.037 at the end of a month. So it is as good as SGLT2 inhibitor in HFpEF patient or even HFpEF patient. So within a month, you are getting a significant benefit. And then it is a sustained benefit, not a short-term player, it's a long-term player. Even after 3 years, curves are still separating and p-values are getting better, 0.045 to 0.02 to 0.03003. So it is getting better and better even after 3 years. So that is very important. It is working quickly and it is working sustained. So in 𝗏𝗏𝗁, the absolute treatment effect of finerenone on the primary endpoint was maintained depending on even whatever be the duration of the last heart failure. How long ago it was? It was within 7 days. Well, it is significant. From 7 days to 3 months, yes, it is significant. More than 3 months, well, it is just on the neutral line, but the numbers are not high. But yeah, if you go by statistics, it is not significant. But when you talk about the secondary outcome, the first occurrence of HF event or CV death, then again, within 7 days is just significant. 7 days to 3 months is really significant, and more than 3 months is again a bit less significant. But the trend is same on all sides whenever the patient. But again, it perhaps tells you that you better start it soon, before it is 3 months or more, when you may lose some of the sheen, some of the great benefit of the molecule. So better start it within 7 days of the last event. Perhaps that we can take home from this, though it is not very scientific. What are your primary concern for this patient? Increased risk of adverse clinical event in this patient, and finerenone in the FINEARTS trial reduce the risk of primary outcome versus placebo consistently across the age, the gender, with or without background therapy. And so it is really an universal molecule. If you see over here, to emphasize the point, consistently across the spectrum of age, from 50 years to even 87 years. The last entry was 87, 88 years, and they all drew equal benefit. And here, if you also see on your right, the absolute benefit was also pretty consistent and of same magnitude. So my presentation was very short. So I just keep a question to all three of you. Which indicators are critical for assessing long-term outcome after discharge of HFpEF patient? And also, what are the most significant barriers to effective management after hospital discharge? Dr. Chopra, please.
So, Uday, may I have your thoughts, please?
Yeah, I mean, so if it's related to long-term absolute clinical outcome, I would still look at the quality of life, the cancer score. I think that's very relevant of how you're following up your patients in clinical practice. 1, 2, I would certainly look at the hospitalizations that are coming up, the requirement to get back to their cardiologist. And 3, of course, if it can prevent atrial fibrillation, that's great news in HFpEF patients. So those are the 3 long-term things I start looking at. Significant barrier in the effective post-discharge management is stay tuned to optimize all the heart failure recommended drugs for HFpEF, and that's very few right now. SGLT2 inhibitors at 10 milligrams. And even when we try to do that, one should try and avoid a lot of drugs that can upset the clinical status of even HFpEF, exactly like we did in HFrEF. For example, the use of NSAIDs and the clinical aspects that leads to increase in potassium that has to be paid attention to. They're equally important. Thank you.
Sanjay?
Yeah, so I totally agree with Dr. Uday. I think if I look at the heart failure with preserved ejection fraction markers of outcome, quality of life and hospitalization for heart failure are important ones. Along with that, new onset atrial fibrillation and diabetes. Both of them, because it's a comorbid situation with heart failure with preserved ejection fraction, we should be watchful. And also the emergence of kidney dysfunction. These are important factors for me. And if I look at the barriers, I think bluntly I would say cost of polypharmacy. Vis-a-vis the understanding of heart failure with preserved ejection fraction not being as dangerous by the people around is something which is a concern which we have to address to. And the second thing is nowhere ever we have been able to produce mortality benefit in heart failure with preserved ejection fraction in only all of those class 1 indicated medication as of now. Probably, we also know that mortality in heart failure with preserved ejection fraction usually is because of comorbid situations rather than heart failure itself. And probably, I would say that all those molecules which help in comorbidity management simultaneously should be preferred. Cost is definitely going to be one of the concerns for polypharmacy.
Sanjay, if I chip in, I think in DELIVER trial, dapagliflozin showed mortality benefit.
No.
No, not really.
No.
So I think
even in the combined Emperor Preserved and DELIVER, it was no different.
Yeah.
Not combined, but in DELIVER isolate. Okay.
Even in combined, there was not.
There's no mortality benefit. The combined endpoint was benefited, but it was driven by reduction in heart failure hospitalization, as in every HFpEF trial.
Yeah.
So I think over the last 1 hour, we have had a wonderful discussion. Let me very briefly summarize over the next 2 or 3 minutes that we had. Heart failure with preserved ejection fraction is something which is extremely well recognized in the West. The incidence there is now over 50%. This is totally different than what we are used to, where in our country, heart failure with reduced ejection fraction was the dominant factor. So heart failure, HFpEF is a disease of elderly age dominantly with atrial fibrillation. So in an elderly population, you're going to find more of it. Another very important factor which I read very recently was that with easy availability of early PCIs, people are surviving with relatively preserved ejection fractions in the West, where they can get to a cath lab very, very quickly. So they don't suffer that much of a myocardial damage. So they have ejection fractions of 40%, 45%, unlike our population where we land up with 25 to 30%. So there, the incidence of HFpEF is rising. The same thing is happening in our country also because we have a lot of places where interventions are being done. And then besides that, our population is also aging. We have the highest incidence of diabetes in the world. We are hypertensive. We have a high incidence of smoking. Our obesity is increasing. These are all drivers for HFpEF. So we are also recognizing it more and more, unlike what was happening in the past. So I think the message is when you have a person with dyspnea and you find an ejection fraction of 45, 50, 55%, don't pass it off as non-cardiac. Please check NT-proBNP at least. Also remember that in obese people, NT-proBNP may not be raised even in the presence of HFpEF. So it's very important to keep the total picture in mind. If a person has dyspnea, pedal edema, NT-proBNP is slightly raised or not raised that much, and a person is obese, still think about HFpEF. When you order an echo, as was rightly mentioned, don't just depend upon ejection fraction. There are a lot of echo parameters which are available which assess diastolic functions. It's important to have somebody who knows the echo properly to assess those things. Beyond that, till very recently, we only had diuretics and treatment of comorbidities. Now we have a number of other drugs available. We know that ARNI has a place in ejection fraction of less than 55%. And as the ejection fraction falls, the benefit keeps increasing. Finridone is again another great molecule. It has been shown to be effective in fine arts trial, and it has also been shown to be very, very effective in diabetic kidney disease, which is an important component in many of our patients with HFpEF. So we should be using this molecule more. The advantages are the lesser hyperkalemia, reduction in atrial fibrillation, demonstrated efficacy in reducing the endpoints in clinical trials. Cost is an issue at present, but I think as the drug becomes more and more available, as it is used more and more, like for any other drug, like for any other medicine, the cost is likely to come down. So that is the message that I would like to give. Soumitra, Sanjay, and Uday, any last minute thoughts? Soumitra, starting with you.
Not really. I think it is underutilized on two sections. One is that we are not diagnosing HFpEF enough, and once we are diagnosing, we are not treating as per evidence. So both, there is huge scope for improvement on both aspects.
Sanjay?
Yeah, I totally agree with you. I think, and Sumitra is absolutely right that we should put all the effort into diagnosing, detecting HFrEF, mid-ref, and HFpEF adequately, and then only we can treat them adequately too. We have these molecules, they have to be given to whosoever is fit for them, because they would reduce the hospitalization, which is the major burden of quality of life in people who have heart failure with preserved ejection fraction as well as mid-range ejection fraction.
Dr. Jadhav?
Yeah, so HFpEF basically starts elsewhere in the body and then goes to the heart. So that's where probably the mechanistic properties of finerenone may be utilized. One, and the second comment is that there are only two classes of drugs which spread across the spectrum of EF, if we are still centric on it. That's the SGLT2 inhibitors and finerenone. And finerenone among the MRAs is the only existent one which will take care of all these patients wherever they belong to in that entire spectrum and offer them clinical event reduction besides quality of life. Thank you.
So I think last 1 hour has been extremely educative. Our learned speakers have taken us through the entire gamut of HFpEF in a very, very short period of time. We could have gone on for another 2 hours, but the time is short. The tools are there to treat our patients. The problem is that whether it is reduced ejection fraction or mildly reduced or preserved ejection fraction, many times those tools are not applied properly. So therefore, the patients are derived from the actual benefits which may accrue to them. So let's decide to detect this particular condition more effectively and treat it. Finerenone is a great molecule which has shown a lot of benefit, and we should be using this drug in our appropriately selected patients. With that, thank you very much to Uday, Soumitra, and Sanjay, and over to the organizers.
Thank you, Dr. Vijay. Thank you very much.
Thank you.
And thanks, Soumitra and Sanjay.
Thank you so much, Dr. Vijay, for extremely well moderating this session, and thank you to our speakers, Dr. Soumitra, Dr. Sanjay, Dr. Uday, for joining us. Thank you so much.
Thank you.
Yeah.
Have a nice day.
Good night, everybody.
Good night.
Good night.
Good night.